Hi, I'm Dr. Sarah Hurvitz, professor of medicine at the David Geffen School of Medicine at UCLA, Johnson Comprehensive Cancer Center. It's really amazing to consider how far we've come in the management of HER2-positive metastatic breast cancer in just the last decade or two. In 2006, when I started as faculty, we had one FDA-approved HER2-targeted therapy, trastuzumab, for our patients, and now we have, at my last count, 8 HER2-targeted therapies. But there are toxicities to consider with each of these agents. All of them can be associated with cardiac dysfunction, and so cardiac monitoring at baseline and throughout is recommended for patients going on HER2-targeted therapy, especially if a patient has had previous exposure to an anthracycline or left chest wall radiation. But there are other side effects or adverse events that can be experienced with these agents, including things like interstitial lung disease, and with some agents, liver dysfunction or cytopenias. And so it is important to consider the unique side effect profile associated with each of these agents for a patient who is starting on therapy. This becomes all the more complex if a patient starts on therapy already having organ dysfunction of some sort. For example, a diabetic patient who comes in with renal dysfunction or neuropathy at baseline. One needs to carefully consider which therapy they're going to use. Some of the agents will worsen things like neuropathy or may not be as safe in a patient with liver or kidney dysfunction. Some patients will have underlying gastrointestinal disorders that might make an agent such as tucatinib and capecitabine less desirable from a side effect profile. Patients with pulmonary fibrosis wouldn't be good candidates for example, trastuzumab deruxtecan. So each of the agents does need to be considered carefully in a patient with pre-existing organ dysfunction. That said, when you have a patient who has metastatic HER2-positive breast cancer, one must weigh the fact that they must control this life-threatening cancer in order to extend survival and improve quality of life. And so involving the specialists, such as cardio-oncologists, nephrologists, endocrinologists, et cetera, to help maximize our ability to treat the patient effectively for their cancer while managing and not worsening their underlying condition, that's very important. I think that it is possible to continue HER2-targeted therapy even in a patient with some level of cardiac dysfunction, as long as the patient's cardiac function has been optimized prior to initiating therapy with the use of drugs such as ACE inhibitors. And this can be done, as I said, in collaboration with the cardio-oncologist. Patients with liver dysfunction or lung dysfunction, again, I would involve a hepatologist or pulmonologist and work closely to optimize their underlying organ dysfunction, and then select the agent which is least likely to worsen that underlying condition.